Now that we're being recorded, I can say that this is the Community Paramedicine Insights Forum for January of 2019. See, I just needed a rehearsal so I could get it right with Jonathan Fite talking about cost modeling. So we will mute everybody right now, and then I'm going to unmute Jonathan and get him to say hello.
The conference has been muted.
Jonathan, are you there?
I am here. Can you hear me?
I can hear you.
Fantastic.
So without further ado, I'm going to turn this over to Jonathan Fite.
Thank you so very much, Kevin. Are you seeing my slides? You should be on my title slide here. If you can give me a high sign.
Yes, sir. Go ahead.
Perfect. All right, well, thank you, everybody, for having me here. Thank you particularly to Kevin and Gary for the invitation to talk with you all. As I see in the note here, per Matt, you're right, it is a government holiday, so thank you guys all for taking what, for some people, I'm sure is a day off. But we all know that EMS being a 24-hour business, the show goes on, as they say. So I am here today. Some of you know that, as Kevin mentioned, I do run a technology company called Beyond Lucid Technologies. We have a consulting division within our company, subtly named the brain trust of fire and EMS technologists, which hopefully sounds just like what it is, which is to say we really try to focus on bringing technology and math and other, I guess, largely academic approaches and consultative approaches to some of the thorny topics that are really driving the conversation these days across the industry, be they data or health information exchange or community paramedicine, and how to build sustainability of them. But especially as you see on screen in front of you, what I'm liking to call community paramedicine 2.0, sort of the next generation of CP programs that are built on all that's come before, they're really looking at scaling and in some cases even doing work for their neighbors. So some really interesting business models that are emerging, and we are trying to apply technology and cost modeling and those sorts of skills to what we really think is a pretty vital future for our industry. I know there's been a lot of discussion about whether community paramedicine is going to last. And I think not only is it going to last, it's going to thrive, but it needs to learn from the lessons that it's seen. So this is really a lot of what I'm trying to hopefully talk about today. And some of it is going to get somewhat technical into the weeds. Please don't hesitate to bring on any hard questions at the end. I certainly would appreciate the opportunity to address them. And now thinking about my time in business school, how, especially after a long conversation, you really hope to have a couple takeaways that stick with you, and realizing that this conversation is recorded, I wanted to put these right at the front so that anybody wondering in the future what we're talking about has something to refer back to, and then we'll dig really on in. So there's going to be 3 key takeaways that I wanted to give you. And I hope these provide fodder for ample conversation. The first, 30-day readmission avoidance cycles in community paramedicine programs do not work, except in rare circumstances and in light of particular arrangements with local hospitals and health systems. Most places can't make that model work, and one of the points in my presentation today will be that you probably shouldn't have to. There are more sustainable and reliable economical methods that do not require snapping your operations to a 30-day non-readmission cycle, which ultimately is not likely to result in improved patient care or the cost benefits that the model presupposes. Quite frankly, 30-day readmission avoidance cycles are, to some degree, a convenience born on a mandate placed on hospital systems, but that don't necessarily fit of what we in the EMS world see. Most people haven't looked deeply enough at the nature of the regions out of which those 30-day readmission avoidance cycles have been born, and they are in some ways quite unique relative to the average Fire for EMS-based system around the country. So in today's presentation, I'm going to advocate, hopefully quite strongly, for the use of a more tailored, possibly longer, but not necessarily so, evidence-based cycle that really asks whether you can measure the impact you're hoping to have. In general, I suggest that you promote a 365-day community paramedicine cycle, but you could use 180 days or even 1 to 2 months. The question ultimately is, are the impacts you're promising to achieve measurable in the time frame that you're promising? If so, then great. If not, then you're likely to fail with respect to proving those promises, and that, of course, makes it harder to get paid. Takeaway number 2, and this is something that I don't think has gotten nearly enough play, but hopefully is something that sparks a conversation both today and going forward, which is that perverse incentives to keep people out of the hospital can, in some cases, end up looking similar to patient dumping back out of the hospital system into the pre-hospital system under the guise of something called community paramedicine, but which ultimately ends up being little more than a violation of EMTALA. That ultimately makes your job harder, not easier, and makes it nearly impossible for you to achieve the sustained benefits you're looking for. In the back of my mind as I say that is one particular company in the southeastern United States that claimed to me to have achieved, quote, a great relationship with their local hospital by taking the patients they didn't want, end quote. Not really the approach that we're going for. And number 3, and this again, I hope becomes a longer conversation. Earlier today, I was looking back over the CPIF presentation from Crawfordsville, Indiana. And I was reminded again about something that my dear friend Matt Goudreau, who some of you may know as a community paramedicine pioneer from Massachusetts, when he asked me, quote, what is the difference between a community paramedicine program and an opiate or amphetamine diversion program, end quote. In general, the answer I would suggest is the name and the focus on highly acute patients who are likely to recidivize. So again, a chronic care readmission avoidance program versus an acute care readmission avoidance program. The common complaint about community paramedicine sustainability, of course, besides the finance and economics we'll talk about today, is the politics when they grind against home health nursing. And certainly that's been the case here in California where I'm based. Realistically speaking, most community paramedicine programs do look a lot like home health nursing mapped onto pre-hospital services. But when you focus on patients like opiate and amphetamine addicted individuals, the calculus changes. Now you're talking about patients who are often in an emergent setting and in contexts that are not very comfortable to home health nursing. Most home health nurses, I would purport, who are trained to take care of elderly or hospice patients are not as keen to go into a crack house, a heroin den, or the subway tunnels outside of San Francisco's Civic Center. So therefore, and the bottom line here is if you slice your populations appropriately and end up highlighting what EMS and fire do best, which is run toward the crisis, you can avoid a lot of the politics, and we've been seeing this replicated now across the United States. Some of your patients will be stable, some won't be. Some will be in need of a friend. Others will push back hard on the idea that they need any help because they are seeing help from a vial. But what sets you apart as the service in the field is your ability to adapt. From providing chronic care assistance to building a ramp to ramping up a call to code 3 and administering Noxalone. If you can measure the impact of those services, you can make money from them, and that's what we're here to discuss. So with that sort of lengthy introduction of 3 what I hope are key bullet points, I'm just going to tell you, give you a slide to tell you sort of a little bit about myself. I do run a company called Beyond Lucid Technologies. We are focused on pre-hospital care, documentation and interoperability, pre-hospital health information exchange, and in general, we refuse to be seen as just another vendor. I am currently a frequent contributor to EMS World. I'm a columnist for GEMS, and it is very important to us that we want to try to advance the conversation, not simply serve the conversation around technology, which is largely seen as a commodity. We are, to my knowledge, the only company in this industry that is in fact not founded by a clinician. Neither myself nor my business partner is a clinician. We are surrounded by them, but we are 2 MBAs with a forte in technology and business building and a focus on long-term growth and profitability, or if you're a nonprofit organization, then sustainable and still growth-oriented trajectory for your community. So put it this way, if you're attending today's program, my expectation is that's probably because you're trying to build a program that can last and serve your community. And again, if you're private, that may mean one thing. If you're nonprofit, it may mean another. But in both cases, you're trying to use community paramedicine as something more than a loss leader. My job, whether in our organization or hopefully within the industry, is to try to help that conversation advance. And we've been able to build that operation in multiple states with both on our own and with partners. And again, in order to try to ensure that the conversation is moving, as opposed to staying mired with where the healthcare system was 5 years ago, we have made it a mission to play nicely in the field with others, ensuring that to the maximum degree possible, we'll talk a little bit about the role of NEMSIS in the conversation, that we can play nicely with others and leverage technology so that your daily use systems, whether you're using my company's EPCR or another company's, can share information both with each other to look at a patient's condition over time and with regional health information exchanges, which are really critical to the conversations around community paramedicine, mobile integrated health, data tracking, data sharing, and so on and so forth. And that's really all I'm going to say about my company and our work specifically, but happy to answer any questions that you may have. And again, really trying to bring this sort of academic approach to the science that we're talking about here. Let's say at the end of the day, and again, without trying to sound too money grubby or greedy, I think it's something we can all agree on, that the mission that brings us to EMS, because nobody gets into this business by accident, I am absolutely convinced. The mission drives us on those hard days, and we all know what those feel like. But at the end of the day, for those of you who've seen Wall Street, grew up in the 80s and 90s, remembering what Gordon Gekko said, which is if something's worth doing, it's worth doing for money. And again, I realize that there are a lot of people on this call today, and certainly in this industry, whose number one focus is to make good for their patients and make good for their communities. But smiles don't keep the lights on. And so my job, my orientation is to do good by helping you to continue to do well and better. In fact, as a company, we talk about our four stakeholder groups are our shareholders, our employees, our partner clients, and their patients. And so really ensuring that all of those four communities, those four stakeholder groups are served by ensuring that you're able to keep doing what you're doing more efficiently on a broader scale, and that you never have to look at a novel way of taking care of your patients as something that may not be sustainable. And that really can mean asking some hard questions about whether you need to reorient your program, whether you've stress tested it enough to ensure that it is meeting all the objectives of a long-term sustainable program as opposed to something that's a fad. And again, we really think that community paramedicine has legs, especially when applied to specific patient cohorts that have an enormous amount of need that will be seen over and over again. I can tell you that I have not met a community afflicted by drug-addicted patients where the EMS and fire leadership have not said, we don't know who these patients are. The fact is, in most of those communities, the EMS and fire leadership know exactly who the patients are. And so the idea that you've got these patients coming in and out of the EMS system, and that you know who they are and you can take care of them and you can avoid having to redo all the documentation, and you can string their documentation together and get a picture of their health and how you're impacting it, works whether you're looking at someone with CHF or COPD, as well as somebody who seems to like sticking needles in their arms or taking substances that are ultimately harmful for themselves. So with that said, let's talk about community paramedicine 1.0, where we've come, where we've gone to. At the end of the day, the mission was right. The mission was to keep these patients healthy, keep these patients from coming back, to recognize that some patients are going to be better cared for in their homes or even in their workplaces than to have to call 911 and be transported. And that by keeping them out of the emergency department, it would relieve stress on the system. It would relieve stress on the patients. It would save cost. It would improve health. It would improve access. It would reduce ED crowding, and so on and so forth. But the problem is, by looking at those programs, whether it's because they were clinician-driven or politician-driven, or they were Me Too programs, or they were one-shot grant programs to sort of try things out, by not having these programs start with a business case and start with a long-term trajectory, they have essentially limped along in many cases. And of course, we all know that some programs around the country have received very large sums of money, but have had trouble in some cases keeping their lights on. And some of these programs are remarkably effective to their communities, but at the end of the day, the fact that I made my patients better does not necessarily translate to what's on the ledger. And it doesn't necessarily translate to what goes in the budget. And as much as I hate those words coming out of my mouth, we all know, again, everyone on this call, everyone in this industry knows that we have a dual focus. We have a focus on the now, and we have a focus on EMS 2020 or EMS 2050, or however far out we want to look. And so I think in order to be able to provide care and services to the patients who have a need in the immediate, we have to focus on what we have now at the same time as we try to change the conversation and make sure that the future of this industry is really focused on doing what it needs to do as opposed to what it, how it can justify itself financially. But in the meantime, we should not find ourselves in a situation or rather, what can we do to find ourselves in a situation where the question of funding going away stops the program that is doing good in a community? Because again, almost every community paramedicine program, anecdotally speaking, can be said to have done great things in its communities. And in some cases, you're even seeing startups come in to fill niches. Again, with somewhat rare exception, most startups that come into the world have done so because they see an opportunity, not because they don't. So clearly there is a need, there is a growing need as we go across the country and even internationally to provide better care in the home, allow people to age in place, and so on and so forth. But the question has often been, are you providing do you have the resources to do what you need to do, and are you essentially making the argument for your services such that you will continue to have that? And so some of you on this call will know Chris Montera. I didn't mean to point him out specifically, but this happens to be a fantastic article, and I have an enormous amount of respect for both Chris and Ann Montera. Chris and I sometimes compete for biggest geek in the room when we're at a specific conference, especially someplace like the International Roundtable on Community Paramedicine. And so I wanted to highlight this quote from him. If you don't have that in your community, we're saying you have to have the commitment of a medical director or physician advocate who wants to see change. And this article is from 2016. If you don't have that in your community, you should consider going to community or county leaders and convincing them of the economic benefit of having a healthy population. So again, Chris is a most remarkably rounded thinker about topics ranging from technology to community paramedicine and all aspects of the EMS spectrum. And he's talking here about convincing county leaders, municipal leaders of the value of having a healthy population. What he doesn't really talk about here is how to do that. And another article that came out around a similar time is from PWW, who again, I'm sure a lot of people on this call have an enormous amount of respect for, certainly the EMS lawyers, I believe is their tagline. And here was the comment. The next most significant barrier to the expansion of community paramedicine programs is a lack of funding. Medicare or other federal health programs pay for ambulance transports, but they don't pay for community paramedicine, and insurers don't pay for community paramedicine. While some of that is changing, which I'll talk about in a moment, I wanted to highlight something here that really took me back to my business school days. So you guys are getting essentially 25% of my takeaway from business school. There were 4 things that I remembered, 3 things I won't talk about today, but one of them is something that my professor, Lester Lave, who was an interesting fellow. He died recently, but he was an economist who focused on green energy. So he was very much in a liberal bent, very, very focused on social goods and so on and so forth. And yet his phrase, what he called the iron law of government, and interesting to talk about this amid a government shutdown for a month already, is when government gets involved, everybody loses, right? So it's the idea that if you, and again, that's a quote from Professor Lay, when government gets involved, everybody loses. And what he meant is if you are trying to find a best fit for government to be able to fund a program, for government to be able to support an initiative, the number of stakeholders who are going to be chopping at that program, the number of cooks at the kitchen is such that nobody is going to get what they ultimately want. Nobody is going to get what they ultimately need. Everybody's going to have to sacrifice somewhere. And therefore, if you have a finely tuned local model, for example, on how to build say, community paramedicine or opiate avoidance, or even how to add a new ambulance to your service or raise another fire station. If you are reliant on a diverse government-led group to advance that program, are your needs going to get diluted? And so the question is, if you can leave the emotion out of it, if you can can forget the idea for a moment that we're here to do good by our patients and to make them well, can you prove in terms of hard numbers, revenues, and cost reductions, and so on, that you are actually making an impact, that you are re-injecting money back into the system, or that you are saving money from coming out of the system? And if you can do that, then you can be detached from the whims of government. And so that really is a question that I hope you start to think about on this call and afterwards. Because one thing that I have noticed, and I just wanted to highlight this in the context, as you see on the left side here, the SAFER model of health information exchange that's been widely promoted by the federal government, particularly the Office of the National Coordinator of Healthcare Information Technology, has enormous problems, huge technical deficiencies. There's all sorts of stuff that's just in this book, and it's kind of so broad and so overlaying that it really kind of leaves out huge aspects of importance. And so again, if you are trying to highlight what your community needs are, and you're a small service down near the Mexican border in Arizona, are you able to make your voice heard sufficiently that you get your needs met? So some of you may recognize the Jim Cramer here, and he's got an interesting tag behind him, from the capital to your capital. But one thing that government is really good at doing is starting things. What government is not typically great at doing is finishing them. It tends to spark innovation and then leave it to the markets to continue going. And the neat thing is that the commercial markets are really good at doing that. They're good at having their innovation cycles de-risked and then picking up where they've left off and continuing. So that as long as you can prove your value, and especially right now, there is so much money out there in whether it's the venture world or the insurance world, which is consolidating and removing costs from the system. There are enormous sums of money to support every type of innovation, from technology to service line benefit to the creation of whole community-oriented programs. The question is, are you able to prove it? One thing I wanted to highlight here, for any of you who have not yet heard of a certified B corporation, in general, businesses are measured by how they deliver returns for their shareholders. And of course, even nonprofits that are not delivering profit are measured by how they return, benefit to their communities in terms of new research centers and so on, and access to care. But a benefit corporation is a new phenomenon that is really focused on what they call the triple bottom line, or a social benefit, in addition to customer and shareholder benefit. And so the idea that there are a growing number of companies and some very, very large organizations like Athena Health, one of the largest electronic health record and revenue cycle management companies in the country, that is focusing, you can see here in this title, it's not an emergency, call a paramedic. This is an entire article and case study they did on community paramedicine. Blue Cross Blue Shield, which of course Anthem is one of the first organizations that announced that it would pay for non-transport care, is a nationwide organization that is focusing on readmission avoidance and getting to people before they become addicted to opiates, or helping them get off the sauce so that they can be better and healthier. And if you can provide evidence of the impact you can make on a local level, evidence, not anecdotes, but actual proof, numbers of what you'll be able to do, they are awash in cash that they can give you and all sorts of programs. And lest you think they don't want to, even corporations get a tax write-off for supporting your efforts, right? Most of the folks on this call, and most governments are not, all governments are nonprofit. So the idea that there are benefits that corporations can have by injecting you with resources, but again, you still have to be able to prove the benefit that you are doing. That's really what I want us to talk to here. So what do you need to prove and attract capital investment to your community paramedicine program? And I would argue that it's 4 things in particular, with a bonus, and I'm going to go through each of these in quite a bit of detail. If I tick off anybody in the process, I think that's a good thing. I hope we end up having a robust conversation both today and in the future of this, because I got to tell you, I've been working on community paramedicine program for at least 3 to 4 years, community paramedicine in general, for 3 to 4 years, and I find that every conference we go to ends up saying the same sort of thing. How do we pay for ourselves? How do we justify our costs? How do we keep our lights on to keep doing this program? And I would purport that these are the answers. So if this can change the nature of the conversation going forward, then we've got a lot of work to do, but everyone's going to be able to contribute to it. The first, revenue increases. Now, we are not in the business of making people sick, but there are ways of increasing revenue to your program, which I'll go into in a second. Cost reductions. This is where I'm going to touch a bit on the work that Matt Zavatsky has done. I think he has done an enormous benefit to the industry in terms of focusing on systemic cost reductions, but I think there's also something left out that we're going to talk about. Meaningful, measurable results. Again, can you demonstrate what you're talking about? And the neat thing, as you see in this little bubble here, is, hi, I'm your EPCR. So I don't care which EPCR you have. If you are a Nemesis version 3 EPCR, again, Nemesis version 3. If you are a Nemesis version 2 EPCR, you're late to the party. So you should probably look into switching to a Nemesis version 3 EPCR. But if you're on a Nemesis version Version 3 EPCR, you have the vast majority of data in your system today that you already need to demonstrate this efficacy. There are things you can add to it. There are things around social impact and social determinants of health and so on that you can add, and there are things you can do with respect to interoperability and sharing that data and making it easier for others to consume it. But you have the systems in place right now. I don't care whether you're using my company's systems or somebody else's to be able to demonstrate efficacy in a longitudinal basis, as long as you're willing to undertake the work to do that. So that's what we're going to talk about. And the fourth, and in my opinion, the biggest of all of these, which is the one that is never talked about in the conversations that I've heard at conferences around the country, is risk reduction. Actual, measurable, actuarial risk reduction. The stuff where insurance companies will pay you to reduce the risk exposure on them. And we're going to go into that. And in an interesting way, this is going to touch on some of the debate around education and EMS and essentially what you get out of education when statistics and calculus become part of your conversation on a service level. The bonus here is that it put the ability to do all of these 4 things puts an enormous burden on your partners and your vendors. And in my opinion, as one of those companies, that is a fantastic thing. Our industry has been plagued by vaporware and by big promises for a really, really long time. And if you, as individual services, can find models that will work in your community and model them out and then go to your technology partners, your service line partners and say, this is what I need to achieve. Help me do that. Then they get to step up and do that. And if they don't do it, you have an objective measure by which to say, we have a direction our agency wants to go. And if you're either going to help us get there or you're going to be a hindrance. And that is something that our industry has been lacking for a long time. But I know that there are several companies who are willing and able to step up and help you do that. And that allows us to advance our industry. So let's go through these one by one. First, revenue increases. Again, and I know that I am throwing a lot at you, so hopefully I am. Sorry, by the way, I just noticed a question here in the corner that the slides have not been changing. Kevin, can you tell me if the slides have been changing?
Yes, that's a very old message. The slides have been changing. You're fine.
Okay, great. Thank you. Okay, so again, EMS is not in the business of making people sick. That's always been one of the complications around the EMS business per se, is that bringing people into it, not really the problem. In fact, of course, everybody here is going to be very familiar with the lament that during the 80s and other points, the convincing people to call 911 is a campaign that worked really well to the point where now there are some really interesting and funny calls that you can hear about kids calling 911 for help figuring out what color crayon to use to color something in. So calling 911 for help is not the problem. But now that you've got people using the system, and how do you ferret out to those who can be helped in other ways and ultimately improve your bottom line and the operational ability that you have to service. And one thing that we have seen in some really, really interesting ways, and I'm highlighting here the Carmel Fire Department, which in Indiana, Carmel, Indiana, so not too far from Crawfordsville, Indiana, is that I have had the pleasure of working with for a couple years now, is that they have taken on the responsibility of essentially managing a program for some of their neighboring services, right? So they have, because of the nature of their community and the resources they have at their disposal, they have been able to manage community paramedicine programs for folks like the Westfield Fire Department, which essentially contracts with the Carmel Fire Department to do a community paramedicine program. And while the Westfield team goes out and sees the patients, a lot of the data management and the interoperability and the analytics and that sort of thing ultimately go through the Carmel Fire Department. So if they have actually turned managing a community paramedicine program into a business line. And this is a topic that's also come up in Alameda County, California, where Alameda, the city of Alameda Fire Department, and the county have been widely lauded as having one of the best managed programs in the state. And so one of the alternate programs that I mentioned here, the Whole Person Project, is something that's come up and did come up here in the county. And one of the really interesting opportunities was to leverage the skills that have been grown by the Alameda Fire Department at Alameda County through people like Dan Gerard, who some of you may know, and Dr. Carl Spohr, the medical director, and to essentially spread their services to other departments around the area. And although that's still a gestating process, there are a number of because of the restrictions in California on starting new community paramedicine programs, there has been really an interest on whether other communities could wrap their programs underneath Alameda, sort of like Westfield and some of its Noblesville and others have wrapped underneath Carmel. And again, that ends up not only providing the ability for a community to be served, but for the agency that's undertaking that effort to be paid in the process. Another example of this, so this Bureau of Justice Assistance, which is a program whereby there's just one funding award that recently went out where a number of communities banded together to focus on a drug intervention program. And again, the idea was one of these agencies would serve as point. They didn't really have the resources to go after a federal grant program, but they do have the ability to intervene in their communities once they have the direction from that point agency. So the idea that you can wrap these together and again turn it into a business, we've also encountered agencies around the industry that do this with billing services, right? Or that do it for other training programs in their communities. The idea that you can do this for community paramedicine is just another way of leveraging one area's expertise and amortizing that around a community. Now the next, cost reductions, and this is where, since I know Matt is on the call, and I want to make sure I'm providing enough deference because he has blazed an enormous trail and a very powerful trail advocating for the benefits of community paramedicine. But the idea of reducing system costs without reducing EMS costs has been actually one of the big problems I've seen in the economic model that's been put forth to date. Because at the end of the day, we all know that given the way that EMS agencies are paid across the country today, with the exception of the dabbling that Anthem and others are coming into it, is that you only get paid when you're moving, right? So even though the system may benefit from not having certain patients come back, or your municipality may benefit from not having again, certain patients being paid on through public insurance and so on, the question is, are you benefiting? Because at the end of the day, the costs associated with service continue to accrue, right? So time and gasoline and insurance, and EMS does not make money on coffee and smiles. So not to put too fine a point on it, but you can't do community paramedicine if you're bankrupt. And so the idea that there are costs that go into your service that don't get translated through in the interest of looking at systems savings is a very useful way of looking at the economic model in some places, but not in most places. And as I've been looking at EMS agencies across the United States and even internationally that are trying to justify these types of programs, one of the places where they continue to grind is on the fact that they are effectively losing money by doing these programs because they don't have the ability to justify to whoever is what they want to pay for this service that the cost they have expended and the opportunity cost of time and value beyond the cost are there, right? You need data to do that. And so the fact that our EMS agencies already absorb over $3 billion in uncompensated care. This is care that you are delivering in a 911 environment where you are not getting paid. And if you are now going out and providing proactive care and you are not providing enough support of what you've done to be able to prove the value, then you are literally doubling down on something driving you into a hole. We have enough financial problems in this industry that seems problematic. So the idea of ensuring that when we are modeling the ledger and are factoring in ED payments that don't have to go out and charges that don't have to go out, are we also factoring in the EMS costs that are going to be incurred and making sure that whoever is seeing value from this at a minimum covers those costs? And then we get to start talking about value beyond those costs, because one of the other things maybe there's 5 things I took away from business school, but one of the things they teach you in the first semester of business school is cost plus modeling is the least efficient way to build an organization. At the end of the day, you should be basing your pricing on value delivered, not, or in this case, care administered and so on and so forth, as opposed to here's what we cost and give us a little bit more, thanks very much. If you do that, you end up in a very risky situation if at any point budgets go down, costs go up, et cetera, and you don't have a lot of ability to. Third, we talked about meaningful measurable results. So this is where I'm going to start getting a little geeky on the technology bits. But I mentioned NEMSIS v3 EPCR. Show of hands if anybody is not on a NEMSIS v3 EPCR that's on this call. If you are not, you should be. There is basically no reason for you to be on V2 anymore. And trust me when I say it will be worth your while, both in near and long term, to get onto V3. And if you have any questions about that, I'm happy to have a no-cost call with you afterwards to explain to you why the benefits of the rigidity of V3 will enable you to do everything you want to do. So a couple of years ago, in the context of community paramedicine, my team was approached by the state of California and Kaiser Permanente around the idea that Kaiser Permanente wanted to be able to receive data from American Medical Response, from their med system, into the electronic health record at Kaiser, which is Epic. And without going into the whole story right now, although I'll be happy to tell you more detail, we undertook a gap analysis around what it would take to transfer data from an EMS record into a hospital record. And a lot of the people on this call are going to have heard of HL7. I would love at some point to have a conversation around what folks know or don't know about that. But suffice to say that HL7 is the hospital side version of NEMSIS. It's the data behind the record system. And it turns out that to go from a NEMSIS version 3 EPCR to an interoperable document that can go into an electronic health record at the hospital or the nursing home or the doctor's office or the pharmacy, from NEMSIS 3 to HL7, you're about 85% there, give or take. And so the gap analysis was really interesting. We started breaking it down into the types of information that are missing from a NEMSIS 3 EPCR. And again, I'm sure many people here have heard the lament that EPCRs are incident-specific and EHRs are patient-specific, and we need to be looking, switching from incident to looking at a patient over time and so on and so forth. And while I take a lot of issue with that because I think that's a gross simplification of the issue, the fact is any EPCR can be made into an electronic health record, because electronic health records are just encounter records strung together over time. And that's when you go into the hospital. Every time, they string those records together and they see you over and over and over again. But it's not one long record. It's each encounter that you've been in the ED, and they put them together in a picture of who you are. We can do the same thing with EPCR, which is to say, look at every encounter you have and string them together over time. But in order to convert that data into something that the hospital can consume, there are some missing components. And it turns out they fall primarily into 3 buckets: family history, past encounters, and mental health. Which, if you think about it, makes sense, right? Because if you're going into the hospital and you're getting cared for, someone may ask you whether you have a history of diabetes or a history of heart disease. But when you are in an EPCR and you're in an incident-specific environment, it doesn't really matter whether you have a history of heart disease. It only matters whether you're having a heart problem right now. But looking at a record longitudinally, family history, past encounters, and mental health. Leave out social factors that's on the screen for just a moment. But if you think about it, what was so interesting to us is that when we looked at the gap between the NEMSIS version 3 EPCR and the continuity of care document, which is the oldest of the standard HL7 interoperable forms dictated by the Office of the National Coordinator of Health IT, community paramedicine falls out. I want to let that simmer for a second. Family history, mental health, and past encounters are the missing link between the EMS data and the hospital side data. And if you add those three buckets of data onto the NEMSIS version 3 EPCR and you properly format the output, you get the CCD. Or specifically, you get the clinical document architecture, of which CCD is one type. So take the EPCR, NEMSIS version 3, add the supplemental data elements, and what you end up with is a document that can be kicked out of your EPCR and converted into something that your hospital can consume. Because one thing that I want to highlight, because there's a lot of talk right now about how to share information both in 911 and community paramedicine environments with a hospital. This is all standard stuff. It is not proprietary. My company doesn't own it. You can find this information on the Office of the National Coordinator of Health IT website. I believe it's healthit.gov. I'd be happy to share that link with Kevin and Gary, and they can distribute it, as well as a bevy of other links on how to do this. This is stuff that your taxes and mine have already paid to do. And in fact, in our case, the California Healthcare Foundation funded us to do this. So this is a demonstrable way of enabling you to take your pre-hospital data, string it together, add all the stuff that you need to know for community paramedicine anyway, and output something that your hospital can then consume, which allows them to basically follow along with you and even give information back to you. Although that's a bit more complex conversation. Your ability, as I mentioned, even if you are not utilizing a community paramedicine oriented EPCR, the majority of the information that you are going to want to ask of yourself in a community paramedicine environment is already contained within your NEMSIS version 3 EPCR. For example, here's just a fake quote, but our patients' needs seem clear. We need to invest personnel time in checking on the managed care cohort, whoever it is, then run the data to see how they perform over time, following our interventions. If we show meaningful impact, we can justify our pricing. Well, if we want to focus on diabetes patients, I talked at the beginning of the discussion today around slicing your patient cohorts in such a way that you have control over who you're going after, rather than focusing on CHF and COPD and diabetes and fall risk and sepsis risk and opiates and amphetamines. Maybe we pick one. And in fact, the woman who's highlighted here is Tangi Beckham. She is the EMS coordinator for the Rio Rico Fire District in southern Arizona, who actually just got named one of the GEMS 10 the GEMS innovators, which I was honored to have an opportunity to interview for GEMS. If any of you wants to go look up that article, it's on the GEMS website. She has built a specifically fascinating program for that district with a focus on dementia. And that's something I'd never seen anywhere else. But a focus on patients who are falling into these interesting social cracks where they make too much money from pensions to qualify for public benefit, but they don't make enough to pay for their care, and they are oftentimes living alone or living with somebody, but they have memory problems, and she has focused on making them better. It's very easy for her to justify the cost of her program to her community because she can show meaningful benefit. If you are looking at tracking diabetes patients, all the glucose information that you're looking to track is in your EPCR. You don't need something special to do it. There are additional benefits you can use get by using a system that tracks that information for you. It makes it more efficient. It might make it more interoperable, but at the end of the day, you can show meaningful benefit by using the information that you already have, as long as you focus on meaningful benefits that map onto value. And that's really the last bit here, value. Okay, so actuarial risk is something that I have almost never heard in this industry, and I don't really know why. In fact, I find myself wondering why. Because if there's one thing that EMS and fire agencies are good at, it's reducing actuarial risk. For those of you who have never heard of actuarial risk, that is insurance risk. And it's a risk that you are going to come back and cost somebody money. Insurance companies love taking care of you as long as they never have to take care of you, because they want you to be in their system, they want you to pay the premiums, and they never want to actually have to pay out anything. It's a really great business to be in if you are into that sort of thing. And what we have found, and I highlighted, I highlighted a couple areas that I'm sure you know have had a significant focus on community paramedicine, both in the past and now, like Massachusetts, which just kicked on its programs again, in that in each of these places, the role of insurance and insurance providers and managed care organizations in driving the conversation has been compelling. In fact, our company started in Pittsburgh, so I distinctly remember the time before Highmark Insurance bought a variety of different hospital systems in the area and created the Allegheny Health Network. But UPMC and Highmark are both insurance companies that run emergency departments and command ambulances. And the idea that there is a cost benefit to them to have patients kept out of the emergency department and shifted into a lower cost environment goes directly to the insurance company's bottom line. So it makes a lot of sense to look at, if I am helping you do that, if I am shifting your patients out, if I am keeping your patients in their homes in places like Minnesota where there's large open spaces, and I can keep you in the home instead of having to having the insurance company that have to pay a transport of maybe an hour and a half, long distance transport. That makes a lot of sense for you to be able to say, we have contributed to the savings you have incurred. We have contributed to your bottom line. You need to pay us for our work. The question is, can you prove it? And that's really where the opportunity comes in before us. So again, without getting too deep into this education conversation that I think is really ripe and interesting and thorny, there is a lot on this slide. There's some calculus on here. There's some statistics on here. At the end of the day, forget all of that and think of this as a way of saying, can I get paid to reduce your risk exposure? Okay? So we go back and we look at the things like a heat map around the illustration of historical improvements in mortality by both age and calendar year. If you look at on this curve, which is an interesting calculus example, a graph showing the relative risks of age and cigarettes per day, but for white males and white females. If I can make these numbers and the odds of death shown in the table at the right, which come from sources including the Society of Actuaries and a variety of sources that are listed at the bottom. Again, I'd be happy to share those citations with you and you'll see them in the stats. You can translate these numbers to meaningful financial benefit. For example, if you have a COPD patient who smokes 6 packs a day, and in fact, I have a family friend, who has lung cancer and COPD and still smokes 4 packs a day, and I can get him down to 1 pack a day by checking up on him, I am reducing the risk, at least to some degree, that he comes back for one reason or another. Can I measure that? Can I measure that over time? Can I measure that at any given time? And your ability to reduce the cost that an insurance company or a hospital will pay to care for that person as he continues to put tobacco in his body and smoke in his lungs translates to money, as long as you can demonstrate the differences in the care with or without your service. And that requires understanding how to measure the impact that you are having. One of the things that is missing from the EPCR, but is often seen in the social items that folks are modeling and the risk factors associated with care, are consumption of harmful substances, right? Do you drink a lot? Do you smoke a lot? Those are not in NEMSIS, but they can be modeled and they can be tracked over time so that you can use them to contribute to your model. So let's talk about some of the findings to date and why these matter. And I got to note that I'm at 45, so I'm going to try to breeze through these, but I'm happy to come back to these during the Q&A. If we talk about how we're going to prove the value of a CP program, why, when I say, for example, that a 30-day readmission avoidance cycle does not map onto the data, Why do I say that? And again, I talk about this COPD patient. And COPD patient. Let me use him as a perfect example. Because here is an individual who is very smart and should know better, but I can guarantee you that one of the things that he has not done while he has been in, while his health has been deteriorating, is go to a doctor, right? He's not getting regular care. So if I'm looking at him over a 30-day readmission avoidance cycle and I am going and taking proactive care of him and trying to make sure he's getting the care he needs, what does that do to the cost of care that I'm actually giving to him? If I am actually ensuring that he now goes to the doctor and that he gets the medicine that he requires and that he gets and that he is using alternative methods to keep himself from smoking and so on, if I have promised to reduce the cost of his care over time, and he has not gone to the doctor in 4, 5, 10 years while he smokes that, sucks down these cigarettes and doesn't want a doctor reminding him that he shouldn't be doing that, but now I get him into a program and I take care of him and I make sure that he gets to his appointment, which is of course what so many community paramedicine programs do, I'm actually going to increase the cost of that patient on the system. And in fact, that's what we see in a variety of the different types of community paramedicine programs, is that the costs associated with patients, with a few exceptions, but in general, the cost associated with these patients goes up within 30 days, not down, because you're actually making sure they're getting the care that they have deferred over years in some cases. To use an example of a patient who drinks a lot, I mean, how many of your patients are chronic alcoholics or substitute another drug for alcohol? The literature shows that the healthcare costs associated with non-drinkers who used to drink but no longer do is $2,421, as opposed to a drinker now that only costs $1,358. So if you're actually looking at the cost of this patient on the healthcare system, you actually save some 30% by keeping them out, by letting them stay in the healthcare system as they are, which is not very much. Because when you bring them back into the system and they have withdrawal and other things, they start to notice that we're getting masked by the alcohol, and all of a sudden they have this snapback effect, and you're making sure they're getting the care they were missing. They jack up the price. In fact, it's 30% up, 50% the other way. So their costs are skyrocketing. And you see the same thing in other substances. For example, former smokers. And this is from Health Services Research. Healthcare costs among former smokers increase relative to continuing smokers in the year after cessation, but fall to a level that is statistically indistinguishable in the second year. So think about that. You take my friend who has lung cancer and COPD and is sucking down 6 packs a day, and you get him off. Now he's going to have migraine, he's going to have stomach pains, he's going to be eating to compensate for the cigarettes, he's going to be doing other things, and he's going to put himself back into the healthcare system over and over and over again, not necessarily related to smoking, but related to all the stuff that comes after it. And that's because you're now sending him to the doctor, and you're getting him the care that he should have had over the last 10 years. So amortize that cost over 10 years. And now you see his true cost of the healthcare system. But after a year, he starts to revert to the mean. And what this means for you, which I don't have this specifically on a slide, so I wanted to make sure I underscored it both at the beginning and again now, is if you change the scale on which you're measuring your program from 30 days to, say, 180 days or 365 days, or a 1-year check-in with a second-year check-in, you can show value over and over and over again, and you can prove that the impact you're having is making people healthier and helping them revert to the mean. Because in the 30-day period, you have a snapback. If you're doing the work as you want to clinically, you are making them better. You're making them healthy, but you're making them expensive. And if your promise to the healthcare system, whether it's a hospital or insurance company or a state, is that you are going to make their costs lower, then you look like a liar. And that's a problem when you want them to come back and renew your program. So instead, we have to properly structure the program and avoid focusing on the 30-day readmit that has to do with hospital readmissions and penalties and all that, and it ultimately has nothing to do with patient health as such, and it certainly doesn't affect the types of care that you're going to see. Because when you bring this person back a second and a third time inside 30 days for different health conditions, the hospital gets paid every time. The readmission bit doesn't even apply. Now, there are some areas where the readmission avoidance and the 30-day cycle do impact directly. And I want to make sure I focus on those. And those two, which are starting to finally get attention, are access to food and access to friendship. And those are really, really important. We're talking a lot about that in our industry, of course, around PTSD and open door policies and allowing people to express their feelings and try to avoid the mental stress associated with the job. And the same thing happens with patients. So first of all, the financial cost of hospital admission for hypoglycemia was $1,200 in 2003 and has gone up. Now, this is the idea. There are patients who don't have food. And if you get them food, they stay home. A perfect example of this is told, I get a chill every time I tell it, for Alameda County, where there was one patient who was being seen every couple days in Alameda County. And it turns out that the primary complaint, or the primary impression, I should say, that the crew saw was that she was chronically malnourished. And when the community paramedic team, led at the time, I believe, by Gail Porto, went to her home and checked on this patient, it turned out that she had food stamps. She qualified for food stamps. So why was she malnourished, they wondered? And it had nothing to do with the government shutdown, although that's another problem that's looming. But rather, it's because in California, you need an ID to get food stamps. And this woman couldn't drive. She was basically bedridden, chronically malnourished, couldn't see very well, and so she couldn't drive. So she couldn't get her ID, so she couldn't get her food stamps, so she was calling 911 over and over and over again. So the CPs went to her home, and they drove her to the DMV. And they got her an ID. And then she got her food stamps. And then she didn't call 911 except one time in a year for something completely different, like she hurt her hip or something like that. And I thought it was such a telling story because, of course, we all know on this call and who are doing this practice that there are other non-clinical reasons that people are coming into the healthcare system. But the ability to focus on loneliness and food access are two of the most meaningful that we have. And the loneliness one, I want to make sure I touch on here because it really comes up over and over and over again, and people are finally starting to model financially the impact of having someone to talk to. Again, not something that you're not getting paid today to go into someone's home and sit with them and talk to them. But maybe you should be. And that becomes an interesting opportunity for you to build into your economic model that you are going into someone's home and you're incurring costs to do so, and you are paying for gas and paying for time and so on. But if you generate system savings and you generate insurance savings because this person is no longer as sick, if I can model that impact, then what is your contribution margin to that conversation? And that's where we need to go. Which gets to the conversation about shared savings, and I promise I'm almost done here. But in the shared savings model, which again is a lot of the work that Matt has done and that others talking about this have done, and they deserve enormous credit. The shared savings model is based on the specific formula. And it's not brief, but here's a little quote on it. So each benchmark year, CMS calculates average per capita, risk-adjusted, yada, 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 yada. In English, it means determine how much a patient cost over the last 3 years, then see how much they cost going forward to a specific point. And if the cost savings are realized, you take the savings and you divide it up by the people who touched the patient. That's basically what it is. So the question is, how much have your patients cost? And I'll tell you, one of the most sophisticated places I've seen in the U.S. on this, which I hope becomes a model for doing statistics nationwide, is Tualatin Valley Fire Rescue in Oregon. They have such a granular view of the impact and the cost of their patients on the community that you can look at any given patient and you can see whether you've gone from bright red to yellow on a heat map. And this conversation is happening more and more. Again, you have this information in your EPCR. Forget the idea that you need a longitudinal charting system. That's helpful for different reasons, largely to automate some of this work. But you have the ability to understand that if you have a patient who needs a finger stick checked and you are checking on them X number of times at Y cost, you can see how much they cost you last year and the year before and this year. And if you only have to do it Y divided by 2 number of times in the future, you have a system savings. And so you can go to whoever is responsible for paying that and say, I've saved you money. but you have to be able to prove it. And you have to be able to factor into that calculation all of the costs associated with your work. Again, you need a ton of information for this, but every EPCR that you are doing today in NEMSIS version 3 has at least 550 or so data points. There's a ton of information, and this is the only industry that I know of where you achieve statistical significance in most regions inside a week or two because our volume is so high. So as opposed to doctors' offices, which have they have a lot longer period before they can get to statistical significance. So you can start to model this information retrospectively and going forward. And I know there are agencies across the United States that are starting to bring in-house the expertise to slice and dice your data. And if you have the ability to model out statistics and calculus, and you don't even necessarily need complex math, or to come to an organization like mine and say, help me run the numbers, these types of, you have the information that you need, you just need to know how to get it. And there's a lot of conversation right now about modeling 911 impact between fire and EMS, right, to show what fire-based EMS does versus private EMS and so on and so forth. There's been a lot less conversation around community paramedicine. And I would argue that's actually where it's easier because you can show discreetly what you've done. String together the data, ask what you're trying to seek. How are you trying to measure it? How narrow is your focus? And I would argue, like they say in startup businesses, if you maintain focus, you're likely to do really well at that, and you can always expand out as opposed to covering 6 or 7 syndromic states, disease states, patient types, and not necessarily getting good at anything. So just 2 slides left. Again, just sort of recap. So to establish a profitability model, the first is understand what you cost, right? You can't run a profitable organization if you don't know your numbers. And there are actually some entrepreneurial mentors, and if you ever watch Shark Tank, for example, they will say, if you don't know your numbers, you don't have a business. So if you need to have an understanding of what things cost, and not just salary, but gasoline and time and marketing of your services to your community. Would it be interesting if you took some of your marketing budget and you turned it into a community paramedicine program? Because guess what? Your healthier patients become your marketing team. They tell all their friends how great a job you did. And that could be worth its weight in gold when it comes to public relations. It could be a whole lot better than buying buttons or, et cetera, et cetera. So understanding equipment, time, insurance, the costs that you incur to do this program need to be modeled into your finances. The second, what are the revenues? The revenues that you are generating, the revenues that you are, or the costs that you are offsetting to other people. So insurance payouts that they don't have to do can translate to revenue to you. Not 100% because they're not going to want to give up all of that, otherwise there's no incentive to do it. But let's say you split it 50-50 or 80-20 or 20-80. If there's money you're saving someone that they don't have to pay out, you have to be able to prove how much it is. But once you can prove how much it is, you can claim part of it. Or if they don't want to pay it, go back to how it was before. But obviously we know that since that's a conversation that's growing across the country, there's not an interest in that. People want to save money, and especially if you're a for-profit or a public organization, they want to grow the top line. The third is this risk mitigation, understanding who your patients are and how you can impact them. And does it make sense for you to be a jack of all trades, master of none? Or does it make sense for you to focus on 1 or 2 disease states that are huge in your community and that are different from home health, for example? Again, looking at Tangi in southern Arizona, focusing on dementia patients if those aren't the patients that are currently being served, or focusing on the patients who are falling through a crack. And becoming so good at that people start to say, if you did this well in this program, could you do just as well in an adjacent program? And you start to, again, like any startup, you start to wring out the kinks, right? Wring out the slack, and you build a tight organization that runs a tight ship and that allows you to diversify and then manage your program, manage programs for others that becomes a revenue line to you, because you've gotten so good at this that you can manage broader programs by replicating, essentially building a franchise for yourself. And really, here's my last slide, because we talk about data, and this obviously I take a little personally with respect to my day job, but people like to hate on data in this industry. It's still seen in many ways as an evil, necessary or unnecessary. There have been moves made to push back the next version of NEMSIS. I think it's a mistake. I think it's a huge mistake, especially the closer we get to talking about the role of EMS and fire as part of the broader healthcare system. Whether it's the hospital system or the front edge of the hospital system or health information exchanges, et cetera. At the end of the day, NEMSIS is like a cup. HL7 is like a cup. The data are the soda. If your soda isn't good, let's say, or to use more graphical terms, don't blame the cup, right? So there are flaws with Nemesis and flaws with HL7, just like there are flaws with cups that have wax on the inside and can't be recycled. But that doesn't mean that they can't be used quite effectively every day to do what you're trying to do. And as an example of the flaw being in the data and not in the cup, so to speak, I wanted to highlight something that we observed in California in October of 2018, which is my team published 16 pages of errors. 16 pages of errors in the California core measures from 2017. That means for a year or so and up to 10 months, or whenever that thing was published in 17, EPCRs and agencies and counties and health information exchanges in the region have been running data on garbage over and over and over again. No one bothered to catch it. We took this stuff to the state of California and said, they said publish it. These errors are in the core measures. If we continue to talk about data as a necessary, as an evil, rather than looking at what we're trying to achieve with it, then we can't answer the questions around the value that we're providing and the cost that we're incurring and the revenue that we're generating, because we're pushing back on the answer key, which is the data. We have to look critically at the data. We have to understand where the data that we're collecting are meaningless. And there are some data points that are meaningless. So, and there are some of those in the California core measures. There are others that have errors. There are others that should be elaborated on that aren't. And when you look at, again, the questions that we want to answer as an industry for community paramedicine, whether it's for chronic care or acute care, the data are already in your hands. And that's really what I want to emphasize. There are so much hate of EPCRs across the industry, yet they are the answer key. And I hate to sound self-serving because my company makes one, but they are the answers to doing these programs sustainably and profitably. But you need to sort of dig into them and understand that the information, you already have the power at your fingertips. You just got to learn how to pull it out. So thank you so very much for letting me step a little bit onto my soapbox here. And I'm happy to take any and all questions. Thank you guys very, very much.
Jonathan, thank you. Appreciate your sharing all of this with us. If you all be patient with me for just a second, I'm going to unmute everybody's line.
The conference has been unmuted.
And this is an opportunity for anyone on the line to simply speak up and forward a question or a comment.
If you have a pitchfork, I ask that you just be gentle. My body is rather soft. Anybody awake?
We still have everybody on the line. You didn't lose a soul. But apparently they're all believers.
Sounds good to me. Should have given this talk years ago, Kevin.
Yeah, very much so. Not to put you on the spot, Matt Zavasky, but you're certainly a voice of reason in this arena. Is there anything you'd like to add to Jonathan's comments? Or
first, thank you, Jonathan, for your passion. Thank you to CPIF for hosting his webinar. Very interesting information. I would agree 100% that the profession needs to continually find new ways to bring value to a myriad of healthcare stakeholders, that they would be willing to fund us in different ways that would allow us to not only enhance the services that we provide, but also to enhance the education of our practitioners, to even bring more value. So however those stakeholders are going to determine value is to some extent dependent on what they're at risk for, much to what Jonathan had mentioned during his webinar. And thank you for bringing the information to light, John. Great job.
Thank you so much. That means a lot.
Thanks, Matt. And I certainly would, I'd underscore that. And just for anybody who happens not to know Matt Zavasky, I would point out that MedStar and and he and his colleagues have been at the forefront of finding exactly that kind of value and pointing out its importance to people in the healthcare system in Fort Worth and surrounding, and making a success of it. Joan Field has a question, says, awesome content. I am digesting the large amount of content, and it was quite a brainful. Can this be joined with a community health worker program?
Is that for me? I suppose that's for me. I'd argue absolutely yes. I think what I'm hoping that I was clear enough, and if I wasn't, let me be right now, that I'm really advocating for a way of thinking about the models, right? It doesn't matter, or shouldn't really matter, what your titles are, or even the role that you have. Whether you're fire, EMS, public, private, community health worker, home health nurse, right? The title matters less than the core finance. And this is something that, when I talked with Kevin about how to put this program together, I asked him that very question of sort of how technical should we get, right? And the business management functions are the same, right? Knowing, again, just going back one slide here, knowing costs, revenues, and risks is really, that's central to any sustainable, growth-oriented enterprise. So I think what works in your specific community, and even how you deal with the local politics, is a matter of what I would say letting the numbers do the talking. If you have different levels of practitioners who can do different things, those go into your different lines of service, and you can model the contributions that each of them do in that community. By doing that, it also shows you the white spaces, right? And again, that's one thing, going back to what EMS and fire, especially the two organizations, EMS and fire, do best, is adapt, right? So if it turns out that there are white spaces in what your community currently needs as opposed to what you have, that's where you can focus. And in my opinion, that also helps you bring together the organizations rather than having a tribal approach to, we do this, you do that. It really becomes, this is our part of the pie, and this is your part of the pie, but together it's a pie. And so everyone comes together. And I think, interestingly, I know that the last conversation that you had, I think it was last week, was with a company that focuses on that community engagement process, right? And so the idea that you have multiple stakeholders, some of which are going to have patches on their arms, some of which aren't. And at the end of the day, we're all focused on a common end, which is improving the health of our communities. So I do think it works in all those ways, but the underlying science is common, the management science.
I think you're right. Joan says, perfect, I get it, thank you. And, I would say, too, that if you're looking at what community paramedicine adds to the EMS providers' armamentarium, it's familiarity with chronic disease and such, and also and the ability then to deal with that effectively, at least in the limited fashion. And then the other is a knowledge of resources that can be used as alternative resources other than an emergency department in which to benefit a patient. And community health workers are the absolute pros at that. That's exactly what they're all about, is knowing what types of resources, both social and health and medical, exist in the community and can be used for various solutions to a patient's problems. And so certainly I think your comment is very well founded and certainly does fit into this overall model. Are there any other questions or comments that people might have?
Kevin, if I can throw one thing out to the community health worker conversation. Many states, because of the evidence base, World Health Organization has studied community health workers around the world for a very long time, and they've got evidence-based outcomes. Because of that, many Medicaid programs in the state do provide reimbursement for community health workers, each one is a little bit different in how community health workers are engaged, but you may find in your community that that level of personnel as part of your EMS-based MIH or CP program could be a reimbursable expense.
Good point. Thank you, Matt. Other questions or comments? Okay, well, I think I'm going to call it a day. We've had a good long program. Jonathan Fite, I want to thank you again for your contribution to our knowledge, and that contribution will go into the archives page on the cpif.communityparamedic.org website that you all registered on, and will be there within a couple of days. And I'd like to thank you all for attending. I apologize for having run a program on a holiday. Last year we got hammered for doing it 2 holidays in a row. So last year, 2 years ago we did. Last year we put it on President's Day. This year we're putting it on MLK Day. And we will not have a program next month on President's Day to let all of you folks who do recognize one day or the other have one day or the other completely off. And we'll come back to you in April on the 3rd Wednesday in April at 3 p.m. Eastern Time. And so the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research all thank you for having attended today. Have a good week.
Thank you so much.